Assalamualaikum and good morning to everyone. I'm Adlinda Alip from Clinical Oncology Department. It is my great pleasure to chair this morning breakfast at UMHealth and also to introduce you our speaker for today. Associate Prof. Marniza Saad is a clinical oncologist and she joined in 2006 after completing her training in UK. Her interests or her side include gastrointestinal, lower GI, breast, sarcoma, but I would say her great passion would be genitourinary oncology. I can describe her as queen in genitourinary oncology as she is the principal investigator for all of the clinical trials in GU oncology in Without further ado, I will give the floor to Prof. Marniza. Enjoy your breakfast.
Thank you very much. Good morning, everybody, and salam sejahtera. It gives me great pleasure to be here on this platform today. Thank you to the organizer, and thank you very much to our moderator for the introduction. Linda is my partner in crime for the past 10 years, and hopefully for the many, many more years later. She's just next to me in the same office. Right, so before I start with my talk, allow me to deliver this short poem. It is a humble one, but meaningful, and was co-authored by Linda and I. The Masquerader. A condition prancing a complex spectrum of pathological characteristics, camouflaged by varied clinical presentations, demanding awareness, requiring high index of suspicion. Look beyond what you see. Save them, our young men. So, to warm up a little bit, we would like to invite you to share with us what you think this condition is. Please send your responses using the chat function at the bottom throughout the talk. Okay, and I hope wherever you are and whatever you're doing, because I know many of you are super busy, I hope you are either watching or listening to us. So please keep the responses coming in. 2 hints. First, Linda and I are oncologists, so this condition must be something to do with cancer. Second, the condition occurs typically in young men. And third, look at this man. He is a cancer survivor. He had this condition. So if you know him, you would know what this condition is. Please send us your responses. Thank you. So I will start with 4 clinical cases that would show you or highlight some of the many features of this condition. And I hope this will help us understand how we should manage this patient. So the first one is a 21-year-old college student who presented with several months of vague abdominal symptoms. He later had abdominal swelling and pain associated with loss of appetite and loss of weight. So this is a CT scan. Sorry, before that, abdominal examination revealed a palpable mass. You can see that's a huge mass there. So CT scan showed this large mass in the retroperitoneal region, and you can see the psoas muscle. So there doesn't seem to be a clear fat plane with the psoas muscle. So the radiological diagnosis at the time includes retroperitoneal sarcoma. So this patient was admitted under the care of our surgical colleague. So he had a biopsy to confirm the diagnosis, and he was referred to us for consideration of neoadjuvant treatment prior to resection. So let's move on to the second case. So this is a 39-year-old factory worker who presented rather acutely with obstructive uropathy complicated by urosepsis and acute kidney injury. Clinically, he had a pelvic mass. CT scan at the time showed the large mass there. You can see sitting on top of the bladder. So let's look at the third case. So this is a 35-year-old accountant. So this is a relatively recent presentation. So he actually presented at the peak of COVID-19 pandemic, when there was a movement control order. So he had a several weeks history, but didn't come until much later when he was more breathless. And chest x-ray at the time showed opacity in the right lung field, as you can see there. and perhaps a suggestion of a widened mediastinum. And CT scan showed a mass in the mediastinum with a lot of changes on the right side of the lung, with collapse and mixed collapse and also pleural effusion. And our final case is a 23-year-old technician who presented with progressive breathlessness and cough. Chest X-ray showed widened mediastinum there and extensive cannonball lesions. CT scan showed mediastinal mass, and you can see there extensive lung nodules suggestive of lung metastasis. So at the time, the top differential diagnosis was mediastinal lymphoma. So a biopsy was performed, and histology, I think, was a little bit difficult. It was described as malignancy of epithelial origin, likely lung carcinoma. So it was started on chemotherapy for lung cancer. After completion of first cycle, he had an acute generalized seizure, and the CT scan at the time showed brain lesion with edema, likely brain metastasis. So we're going to stop there for all those cases. If we look at all of them, what do they have in common, right? Clinical presentation are really varied, but a few things that they have in common, they're all men. And they were all young, less than 40 years old. We know this is likely to be malignant neoplasm. So what could it be? I don't know whether we have any responses in the chat, right? So let's see. Yeah, well done. So thank you. Thank you for that. Okay, we can see lymphoma, leukemia, germ cell tumor, testicular cancer, right? Well done. Okay. So let's go back to this man. I know many of you would know him. So he is Lance Armstrong, okay, the American professional road racing cyclist who once had this diagnosis of testicular cancer at advanced stage with metastasis to the brains, lungs, and abdomen. So he was cured with chemotherapy, and he formed the Lance Armstrong Foundation and became a spokesperson for testicular cancer. So the one thing that they all have in common, they all had germ cell tumor, even though the presentation was really varied. And I'm sure you could see that we were thinking about all the many different diagnoses, but they all had germ cell tumor. So let's look at about germ cell tumor and also the management. So germ cell tumor, primary sites are as shown. It's not common, it's very rare, but among them, 95% of the time, they come from the testis. And this is the main focus of our discussion today. They can also occur in the ovary and also extragonadal, which include the mediastinum, retroperitoneum, and intracranial. I don't treat ovarian and intracranial germ cell tumor because they're managed by the respective teams, but I do treat testicular and also mediastinal and retroperitoneal germ cell tumor. So the main treatment is focused at testis, because that's the most common, and we know most about how to treat testicular germ cell tumor. However, all the other tumor primary sites, we treat the same manner. And if you look at germ cell tumor, we can divide them into a few different subtypes. The main ones are seminoma and non-seminoma. Spermatocytic tumor is indeed even rarer, and it tends to occur in elderly men. So we will focus on seminoma and non-seminoma, and you can see that non-seminoma have many different components. And they most of the time occur together. So what we call mixed non-seminomatous germ cell tumor. And these are the components that you can find in these tumor. So testicular germ cell tumor is very rare, only 1% of all cancers in men. And when it occurs, 95% of them are testicular tumors. It's the most common solid tumors in males aged 15 to 40. Non-seminoma tend to occur in younger men, and seminoma tends to occur in slightly older age, like middle-aged men, but they're still young. It has been described as one of the most diverse areas of human pathology with diverse clinical presentation. So one fact about germ cell tumor, even in advanced disease, is highly curable. You can see here 5-year overall survival in 1970s was more than 70%, and it is continuing to improve. In this era, the survival is more than 95%. Stage 1, when it's localized, the survival is almost 100%, but even in the advanced stage, overall patients survive in 80% of the time. So the aim of treatment is almost always cure, even in advanced stage. One other feature, interesting feature about this tumor, they are highly associated with certain tumor markers. And I've listed here HCG and AFP. So this will depend on the tissue that they arise from. You can see this is the malignant counterpart, and they arise from the various germ cell layer from the normal embryonic development. So you have HCG and AFP. For seminoma, AFP is never raised. It rarely secretes tumor marker though. Only about 1 in 10 men actually has raised in HCG. Whereas in non-seminoma, most patients actually would present with raised tumor marker. So either one of both tumor marker will be raised in 90% of the time. So what's the importance of these tumor markers? They are used for diagnosis, and we use them to stage and also to prognosticate. You'll see that later, and to assess treatment response and surveillance for relapse. So this is again looking at all the tumor markers. AFP is made by the yolk sac elements and HCG by the trophoblastic elements. The LDH is mainly to look at tumor burden, growth rate, and cellular proliferation. AFP is never raised in pure seminoma or pure choriocarcinoma. So if you have seminoma but with raised AFP, so those should be treated as non-seminoma. Beta HCG, one fact about it, it should never be found in normal men, right? So if you have a raised HCG, it is abnormal. So in my training time, that was more than 10 years ago, when our lab technology and service may not be as superb as it is now, it took us about maybe 2 days to get results if we send a tumor marker. So we used to actually do a urine pregnancy test by the bedside, and we'll get the result almost immediately, because if it's raised, we know that's most likely to be germ cell tumor. And so one important fact about these tumor markers, look at their half-life, right? AFP, the half-life is about a week, whereas beta HCG is about 2 to 3 days. So I normally teach my trainee, when we start patients on treatment, we can monitor the tumor marker because it should fall down according to its half-life. Then you know how well the patient is going to do. So the pattern of spread from the testis or from the primary site, it tends to go to the regional lymph nodes. If we focus on the testis, so the regional lymph nodes will be the pelvis and the para-aortic nodes. And then it can also spread to other nodes like mediastinum. Those are called non-regional. And it can spread hematogenously to the lungs most commonly, and also to the liver, bone, and brain. So let's look at the regional lymph nodes. In addition to the pelvic nodes, the retroperitoneal lymph nodes is the very common site. A lot of patients do present with retroperitoneal mass, which are indeed actually retroperitoneal lymph nodes. And it's very typical drainage pattern. If you have a testicular tumor on the right side, it tends to drain to the right para-aortic node. And this is a very typical interaortocaval lymph node that is very typical of right testicular tumor. And if a patient has a tumor on the left side, so it typically drains to the left para-aortic nodes. Again, I teach my trainee, if you see this, right, you can bet, you can win a bet. If you're going to bet, which side of the testis contains the tumor just by looking at the distribution of the para-aortic nodes. And if you look at the route of nodal spread, we've looked at the pelvic nodes and the retroperitoneal lymph nodes. But you can go to retrocrural, which is still a regional lymph node, but it gets to the mediastinum, which is considered non-regional, so metastatic at this point. But what's interesting, it does drain to the left supraclavicular lymph node. And this is an important fact because we have seen many cases, or a couple of cases, that presented with a left supraclavicular lymph node, and they was first seen in the ENT department. So now the importance of the tumor markers, because it's actually incorporated in our staging. Our typical staging for any cancers is this TNM staging, where we look at the extent of disease in the tumor, the node, and also the metastatic sites. But for some cancers, including germ cell tumor, the serum tumor marker level is also incorporated into the staging system. And is also incorporated into this prognostic group classification we call IGCCCG. So you can see we divide into the seminoma and non-seminoma, and we can re-stratify this patient based on the disease location and extent, the tumor marker levels. You can see there good risk and intermediate risk and poor risk, and we can predict the survival. And what I want to highlight is that even in poor risk patient, 5-year survival is approaching 50%, and good to intermediate risk is over 70 to 80%. So high survival rate. It guides our management. So we can divide patients into stage 1, 2, and 3 based on the TNM staging. Generally, stage 1 to 2A is considered to be early stage, and stage 2, B, C, and 3 considered as advanced stage. But importantly, if patient has tumor marker elevation, even if they are stage 1, but with tumor marker elevation, we treat them as advanced stage. So what's the significance of this, right? Interestingly, if you look at this, for most cancers, when it gets to advanced stage, usually the cure rates falls dramatically. But for germ cell tumor, you can see here, even in advanced stage, the cure rate is actually 80% and beyond. So it remains high even in advanced stage, suggesting that we should treat them aggressively, even if they present with metastatic disease. So any breaking news? So how do we treat this? You know, the current standard of care. Of course, currently we're talking about latest drugs like novel agents, immunotherapy, targeted therapies in many cancers. However, in germ cell tumor, it is still the good old chemotherapy that still offers the best chance of cure. And this is just a summary to show you the progression of chemotherapy development from various combinations to more effective combination agents to even intensification of treatment in patients with poor prognosis. And the current approach trying to de-escalate treatment in early disease because patients do so well. So we want to try and de-escalate treatment to reduce the risk of late complications because these patients survive a long time, normal survival. And for those patients with advanced or relapse disease or poor risk disease, we try to aim to intensify treatment with even high dose chemotherapy, for example. And certainly there's a lot of interest in novel agents, but currently there has not been any novel agents that has been shown to be better than chemotherapy. So why do we need early diagnosis and early treatment? Because cure is possible even in advanced stage. And this is highly sensitive, highly chemosensitive disease that you can expect patient to show clinical response in patients who are symptomatic within hours to a few days of starting treatment. However, on the other hand, they are very aggressive, right? So they can progress very rapidly within days to short few weeks. And as they progress, their general condition would worsen. And when patient is less well, it's more challenging to treat. Therefore, we want to try and catch them really early so that they are at the best status when we treat them. Because remember, these are all young men. They're unlikely to have multiple comorbidities. Some do, but most of them do not have any comorbidity. So the only comorbidity is related to the germ cell tumor. And as we delay treatment, the tumor markers would increase. And that will actually move patient from good risk to poorer risk group as the tumor marker increase with shorter survival time. So how do we assess? The first and foremost, I would encourage all of us to always consider germ cell tumor when you see a young man presenting with similar to the cases that I showed you, but with features that suggest malignancy. Always think of it. And good history, especially on whether there's any testicular swelling, because sometimes patients may not offer this history. Okay, and certainly testicular examination to look out for any tumors. Most of the time, patient would have testicular swelling. Rarely, we may have patients who seemingly have normal testis, but on ultrasound scan, there is a little tumor, in the testis. And baseline blood tests should include tumor markers. This is very easy to do as we work up our patients for other causes and also maybe for other concurrent problems like infection. It's very easy to just send off the tumor markers, and in UMMC we can get the results just within 2-3 hours. So as fast as that, and we have our diagnosis immediately. And in those patients who do not have overt evidence of testicular tumor, we should try to do an ultrasound scan to see whether there is a tumor in the testis. And for staging and to look at the extent of disease, it's CT scan. And we include CT thorax, abdomen, and pelvis, and CT brain and bone scan only if clinically indicated. But brain imaging in patients is highly advised in patients with markedly raised beta HCG because they are most likely to have choriocarcinoma component that tend to spread to the brain. And also if they are symptomatic, of course. What is the role of PET scan? So currently it has limited utility as routine staging due to frequent false negative results, but we do use it in certain circumstances. So now the questions that we do get sometimes or many times, is tissue diagnosis mandatory prior to systemic therapy in advanced germ cell tumor? And when should orchidectomy be done in patient presenting, with symptoms of advanced testicular germ cell tumor? And how do we deal with residual masses post-chemotherapy? It's not unusual. They get good response, but they might have 1 or 2 lesions left behind. So these are recommendation from 3 different guidelines: NCCN, ESMO, and also EAU. Oncologists tend to refer to NCCN and ESMO, while our urologists tend to refer to EAU and also to NCCN sometimes. So NCCN states here, when a patient presents with rapidly increasing beta HCG or AFP and symptoms related to disseminated disease, meaning they have high disease burden, they're quite symptomatic, and they are at risk of clinical progression and becoming more unwell, right? And they have a testicular mass, right? And so testicular mass, raised HCG and or AFP, so it's germ cell tumor until proven otherwise. So chemotherapy can be initiated immediately without waiting for a biopsy to diagnose or even orchidectomy, because orchidectomy is not going to be life-saving. What's going to save the patient's life is the systemic therapy, and we can always remove the testis later once patient is well. So ESMO also said the same thing. And also EAU. So we can proceed with treatment without diagnosis and perform orchidectomy later. So what do we do with residual masses post-chemotherapy? So it's a bit different between seminoma and non-seminoma. So usually when you have residual masses, it doesn't mean that they have active disease still. Only 25% of the time in seminoma contains still viable cells. So if the tumor marker normalized, so any residual mass beyond 3 centimeter by ESMO, but by EAU, it's actually beyond 6 centimeter, then we consider resection, right? But this is when we could consider PET scan. If it's negative, then we could monitor. If it's positive, then we resect. Any masses less than 3 to 6 centimeter, we can observe because most likely they are due to fibrosis. And if we scan this patient over a period of time, it will continue to regress. It's a bit different with non-seminoma. So we're a bit more aggressive in resecting these residual masses because not only they could be viable tumor left, but they could also contain mature teratoma about 35% of the time. Of course, about 40 to 50%, it might be just dead tissue. So this needs surgical resection if it's more than 1 centimeter because of the significant risk of residual disease or teratoma. And the thing about teratoma, even though it's actually a differentiated tissue, it's not cancer, it's benign, but it can de-differentiate into carcinomas or other type of cancers like sarcomas later on. And these cancers are not easily treatable or not easily curable, such as germ cell tumor. Therefore, we really want to remove mature teratoma. So what's the role of PET scan here? Not really as useful as in seminoma, because even if the PET scan is negative, we still want to resect it because it could still be mature teratoma. So let's get back to the cases. So our first patient, okay, so what happened to him? So we saw him in clinic, and on further assessment, it was noted that he actually had several months history. In fact, I think about a year or more of enlarged testis. And again, you can see this is mainly on the right side. So he had a right testicular tumor, and we did tumor markers, and they were elevated. You can see quite high disease burden with very raised LDH. And biopsy came back, luckily, also consistent with the results of germ cell tumor. So he was started on chemotherapy, and I'm just showing you the post-cycle 2. You can see a significant reduction in the size of the lymph node, and post-cycle 4 is much smaller, and you can see this is actually an interaortocaval lymph node. And if you look closely at the baseline scan, I didn't point it out earlier, you can see some lesions in the liver there. So these were consistent with liver metastasis, and you can see they resolved with treatment. So the second patient with, so that's the next patient is this gentleman with pelvic mass, right? So tumor markers were elevated, right? Not so much. AFP was normal, HCG slightly elevated, and LDH is quite high. So this can be consistent with seminoma. So this patient, we didn't quite manage to biopsy him. So we treated him based on that, and also based on a clinical finding, because on testicular examination, he had an absent right testis. So this was actually a germ cell tumor in an undescended testis. Right, so based on that, an elevated tumor marker. So we started him on treatment once we were able to stabilize him a bit because he had urosepsis. And you can see the significant response that he had from the chemotherapy. And next patient is this patient who actually presented during the movement control order. So he also had tumor marker tests, and it was highly elevated, all the 3 of them. So he proceeded with chemotherapy. You can see this is at the end of the chemotherapy. You can see the pleural effusion has resolved, and tumor itself has shrunken. And this is residual mass beyond 1 centimeter. So it could be mature teratoma. So we discussed him at our MDT. So he eventually had resection by our cardiothoracic team at the time. And this is his most recent X-ray and scan when we saw him a couple of months ago, still in remission, right, with no evidence of disease. And our final patient, right, who is a little bit tricky, okay, case, because as you remember, I told you the biopsy came back as malignancy, likely carcinoma, and maybe lung cancer. And she was treated with chemotherapy, and then later had a seizure, and the CT brain showed brain metastasis. So at that point, we think again, okay, the primary team thought again whether it could be something else. And that's the time when he had his tumor marker sent off. And you can see the AFP was very raised, more than 100,000. And HCG also quite elevated, quite high. So remember, in HCG markedly high over 1,000, there is a higher risk of getting brain metastasis. So indeed, this was a mediastinal germ cell tumor. That's the primary with lung metastasis. So he had radiotherapy to the brain and then systemic therapy. So he had excellent response in terms of the tumor marker drop and also disease regression, but unfortunately he never achieved remission. So he had relapse and was treated with subsequent lines of treatment later on. So in summary, the treatment strategies we can divide into early stage and advanced. I mainly focus on advanced stage this time, but you can see that in terms of the treatment aim, they are the same. It's curative, and we start with systemic therapy first, and then resection of residual masses and also orchidectomy later. So because it is quite a complex disease, they can present widely to any specialty, and they can rapidly progress. And there is a chance for significant delay in diagnosis and treatment. Therefore, it really demands high awareness among us. So think about germ cell tumor when you see these young men. And these are the varied clinical presentation. Of course, many patients would also present with local symptoms, be it in testis or mediastinum, but many would present to us with symptomatic disease from the metastatic sites. You can see based on the sites, they can present with all these various symptoms, and they can go to any specialties. So please think about them when you see these patients. And it requires high index of suspicion, okay, aware of germ cell tumor and high index of suspicion. So think about it and test for it. And the easiest thing to do is, of course, the tumor marker, good history on testicular swelling, and examination of the testis. And once it's confirmed, immediate referral to either oncology or urology teams. We work very closely together, and we hope we can deliver rapid and correct treatment to these men. And I would like to highlight, you have seen in those cases as well, where there are multiple teams involved, not just oncology. So for a typical uro-oncology case, for example, here, germ cell tumor, oncologists and urologists are the key player, but I want to highlight the support team, which are very important, which include other medical and surgical teams, because these patients might present to you and might later also need your input. For example, that mediastinal germ cell tumor patient, in whom cardiothoracic team play a really great role in trying to cure this patient, and certainly radiologists and pathologists, and also other team members. And I'd like to describe, share with you the next few slides, share with you our experience with the UMMC Uro-Oncology team. And you can see here, that's our going back in history, going back in time. We first started our combined clinic in 2010. So Professor Ong was instrumental at bringing both teams together so that we are stronger together. So we started our first urology clinic or uro-oncology clinic in 2010. So we used to go, oncology team used to go to the old surgery clinic at the time. So we run the uro-oncology clinic together with the urology clinic. And then we moved on to our first tumor board meeting soon after we started our combined clinic. At the time, it was very humble. We didn't have the radiologists and pathologists on board yet, so we did a meeting among ourselves. And later, we managed to get radiologists on board, and this was the physical meetings that we had in the previous old seminar rooms when it was still at the level 2. But now, of course, our radiology colleagues have moved to Menara Selatan. And so we discuss cases every Thursday morning, I think every 2 weeks. And this is one example of one of the meetings where not only we have oncologists, urologists, radiologists, and pathologists, but we also had other team members. So I'm sure you would recognize many of them here, certainly from urology, Prof. Azad, Dr. Yo, and our Professor Ong, and oncology side, myself there, and Linda, and radiologist Farhana and her team. And we have breast surgeon, because this was actually a complex germ cell tumor case, mediastinal germ cell tumor, who had good response to chemotherapy, but had residual masses in multiple sites, the axilla, the mediastinum, and also the parietic region. So we were trying to plan to resect stage by stage. Therefore, we called our breast surgeon, Professor Aisha, for the axillary dissection, and for the mediastinal dissection, the cardiothoracic by Prof. Sharul Amri, and we also had our plastic surgeon, Prof. Alizan. And I forgot to mention Mashita is from the urology side. And many people at the back that you can see here, right, that seems to maybe not play too much role, but they do play a great role because they help to coordinate, present cases. So they are our fellows and trainees in oncology and urology. So this is not just a platform to manage patients, but it's also a great platform for teaching and learning for our trainees. But now COVID has taught us to be more efficient. So then we moved from physical to online, virtual. And I'm just going to show you snapshots of some of the many virtual meetings that we had over Zoom when COVID struck us. And we continue to do so, because it's very efficient to do it online, because we can be wherever we want, wherever we are, we can just join and contribute. So just to show you some of the team members, including our trainees. And this is more recent this month, right? Because we couldn't capture everyone at the same time. And Dr. Chow is our pathologist on board. And then this is even more recent, just last week, right? So Adila is one of our new oncologists who's also doing Uro-Oncology. She might be in the audience listening. And so what do we do at the meeting? So the clinical team, the oncology and urology team will present the cases. This is an example of the germ cell tumor case. And radiology would then present their findings. This is not the same patient, okay, but just to show you. And whenever relevant, our pathologist, Dr. Chow, will also share his findings. And then we will discuss and come up to our consensus of what diagnosis and stage, and then also the treatment options. And this is the typical list that we have, right? Sometime up to 13 patients, but now a bit less because we're doing it weekly now as opposed to 2 weekly. And we only have about 8 patients because we try to finish it, trying to be efficient. We finish it within 1 hour. And all this discussion will actually be recorded and entered onto our electronic medical record, ready for patients when we see them in clinic. So everybody knows the plan and we can execute the management more efficiently. So this is a tribute to all the team members, right? I don't have all the team members, actually. There's some new ones, but I've not actually edited this. So, but you can see generally our oncologists, urologists, radiologists, pathologists, and also some of our researcher. This is Dr. Jasmine from surgery. And to me, it is a love affair, okay, because it's not easy. It takes a lot of effort, coordination from various sides and taking time to actually be there and contribute. So it's not easy, but it is a love affair towards the field and also among the team members that keep us going. So finally, take home messages, right? I hope this would have helped you to develop more awareness. Think about this when you see patients suggestive of germ cell tumor, and take a good history of testicular swelling and physical examination to look for evidence of the primary tumor. And while we try to support the patient and work things up, send off tumor markers, because that will give us very rapid results. And biopsy may not always be required. When you're not certain, do pick up the phone and speak to either one of us in oncology, myself, or Linda, or Dila, or the urology teams, because we work very closely together. And urgent referral is very important so that we can start treatment immediately. So this is like to us similar to myocardial infarction in medical, because when we see any germ cell tumor advance, right, we try to start treatment within 24 to 48 hours of referral. Because cure is highly achievable even in advanced stage, and patient deteriorates the longer you wait. And my final slide to show you examples of many well-known sportsmen who were diagnosed with germ cell tumor before, were treated and survived. So they are the survivors, and they represent the many young men out there who have similar condition. So with that, I thank you very much for giving us the privilege of your time. It's your precious morning time. And I hand over to Linda. Thank you.
Thank you so much for the excellent talk, Mar. And again, I forgot to thank earlier. Thank you for all the participants who joined us this morning. And thank you for still being here. I think the key message is clear in terms of to try and diagnose early and the importance of multidisciplinary team approach. Okay, so we have a few questions in the chat group. The first one is, I think the first question being answered by the subsequent follow-up on the case. How long did the primary team keep the patient before referring the patient to the oncologist? What do you think, Ma? It varies, I think.
Yes, I mean, if you ask how long patients should be kept, I would say as short as possible, right? And therefore, this drive to increase awareness, because I understand it's not going to be easy, because it's always easy for us because when we see patient, the diagnosis is already there. But we have seen many cases where there has been delay. Because of the complexity of the presentation, and people were thinking about various other possible diagnoses. So we've seen patients moving from many different specialties, even up to 3 to 4 specialties, before eventually somebody arranged for a tumor marker. And then the diagnosis actually, came about, from there. And when we saw a patient can be quite ill already. We have had rare cases that we had to treat patient on ICU setup. So this is a rare situation where patient is quite ill, maybe even dying, but we treat them even on ICU setup. And ICU team are usually very supportive because we know this is for cure, and they would improve with the treatment. So I think as short as possible. So therefore, think about it and always take the history, do a testicular examination, and send off the tumor marker. So and pick up the phone and refer to us immediately. We're normally more than happy to see this patient urgently. Thanks.
Okay, so the next question, what is the earliest symptom requiring suspicion?
Right. Thank you for that question. As you can, I had a slide there just now with a varied presentation. So this will all depend on where the disease mainly travel to. For example, if you have somebody with lung metastasis, they might actually present with chest symptoms. If they have nodal disease in the abdomen, so they will present with abdominal symptoms. So I cannot really tell you exactly which symptoms that require suspicion, but you go by the patient profile. So when you get presentation like this in a young man, right? I think the main clue is young men, right? And if the patient also have testicular tumor, that's it, right? It's actually germ cell tumor until proven otherwise. But even if they don't have testicular swelling, it's the young men, right? Think about it, right? And send off the tumor markers. The case that I showed, there's one of the case I showed that I said initially it was thought maybe lymphoma and then a biopsy was performed. That's completely correct, okay? Because certainly a patient with mediastinal mass, young men or young women, lymphoma is one of the common diagnoses. So certainly, yes, think about lymphoma, but also think about germ cell tumor. So while we try to work patient up for lymphoma, we can send off tumor marker quickly. And once we get tumor marker is raised, it's not lymphoma. It's actually germ cell tumor. So young men, that's the main thing. Thanks.
Okay, the next question, I actually wanted to ask you on this. What does the discussion regarding subsequent fertility issues entail? So how do you manage in terms of fertility?
Yes, great question. So I didn't really discuss about late complications. So certainly we know these patients survive, okay? They survive a fairly normal survival. So it's very important that we look at late complications. So we just focus on fertility. So these are young men who just starting their life, right? So we do take history, family history, history on their family and children, etc. And we discussed about these fertility issues because we know chemotherapy can cause subfertility. However, it's not 100%. So there are men after treatment for germ cell tumor are still able to reproduce normally. But we know, it will drop quite significantly. So we have the discussion upfront and we offer sperm collection and sperm storage to all of these men. And we refer them, at UMMC, we refer them to our fertility clinic who are really, really good at giving us early appointment. As soon as we tell them, this is germ cell tumor and we want to start chemotherapy almost immediately. So they will give us a quick appointment and they will have the discussion and patients will then decide whether they want to proceed with sperm storage or collection and storage after the discussion with the fertility team. Thanks.
Thank you for all the questions. Okay, we have the next question. Any screening recommendation for testicular cancer?
Yes, if we want to diagnose a condition early on, so screening sounds great. Unfortunately, there isn't a proven screening program or screening for this germ cell tumor. We have to remember this is such a rare condition, right? So we do not have screening as such, but we hope to make patients aware, right, in patients who have some risk factors, for example, previous history of male-descended testis or undescended testis, family history or personal history of the condition, for example. So those are some of the risk factors that we could look out for. And currently, there's also some awareness programs, about making patients aware or making men aware about germ cell tumor. So then similar to breast, we get patients, women to actually self-examine their breasts. We also want young men, especially those with risk factors, to examine their testes. So that's some of the things that we can do, but there isn't a population-based screening program.
Okay, we have a question from Prof. Azad.
Hi, Prof. Azad.
What I note now is we are seeing more of this patient developing second tumor, especially pelvic tumor among patients who had radiotherapy. I have to say we hardly use radiotherapy now, Prof. Azad, especially in early germ cell. I've not given any. Have you, Mar, in the last few years?
Yes, I have.
No, for early, for
Oh, no,
adjuvant.
early. Is it early here?
No, because it's
Okay.
pelvis.
All right. Okay. Yeah, for early disease, we don't now, but even for advanced disease, radiotherapy is actually not one of the standard options. So we sometimes give it in desperation. So actually, one of the cases that I showed you, the gentleman with the pelvic germ cell tumor from the undescended testis, he actually later relapsed, right? He relapsed after a few years. And then it's not something that we could resect because it's going to be a very massive surgery. We have discussed him at meeting. I think maybe Prof. Azad might remember as well. And it's going to be difficult surgery. We have to remove his bladder and a lot of other organs. So in the end, decided not for surgery, but I gave him radiotherapy after the chemotherapy. And currently, he is still in remission. And that was 2013 when he was treated. And I've now discharged him from my clinic. So I rarely give it, I agree, but sometimes I consider it in desperation when we don't have any other options.
Have you seen a second tumor in the survivors?
Not in my own practice, but I have seen it when I was in training. We had a patient who had, I think, a para-aortic radiotherapy seminoma with radiotherapy to the para-aortic nodes, like many years, and later had osteosarcoma in that region. So I've not seen it in my practice, but maybe because we also rarely do it now for these germ cell tumor patients.
So how do you manage? I think we manage it as as a primary, depends on the HPE as the primary tumor itself, I think.
Oh, yes, that's right. So it will be, if osteosarcoma, then we'll treat as per osteosarcoma. That's right.
So Prof. Chan was asking, can females have germ cell carcinoma as well? So yes, they can have ovarian germ cell tumor. That is beyond our scope. I mean, we don't manage ovarian germ cell tumor. It's managed by the female gynae oncology team. Okay, so there's a question on beta HCG level or other tumor markers as part of medical checkup screening.
What do you think, Linda?
It's actually, germ cell tumor is quite rare. So in terms of screening, I don't think it fulfills all the criteria. I think the key thing is to have a low threshold to check that. If a patient present with any symptoms, young patient, but I wouldn't do as checkup screening. What do you think, Mark?
Yes, I do agree. I think we do not really have evidence of benefit, and certainly this is a very small group of patients. So I think the medical screening out there that we have, many private labs actually do a lot of tumor markers, but I'm not aware whether beta HCG is one of it, but of course I don't want to suggest, okay? But they normally get a lot of tumor markers checked, and it causes a lot of problems actually, because sometimes patients have slightly elevated markers and, without any diagnosis, and cause a lot of anxiety. So certainly I hope the private labs wouldn't add beta HCG as one of the screening markers for all patients. We don't have evidence. Thanks.
Okay, the last question. What is your opinion, experience on self-testicular examination in detecting early testicular cancer? I think that's a good suggestion.
Yes, this is what we actually promote, okay? In fact, if you look up Google and testicular cancer, awareness, etc., you will find, there's a lot of patient education, to create awareness to young men to perform self-examination. And so I think that's the great thing to do. And certainly those who have risk factors, should be more aware and do this regularly. In fact, we also train all our patients who had testicular tumor. Then we train them to do this because, of course, they have the contralateral testis to look after, right? So usually when we see them in clinic, for normal follow-up, then we educate them on how to do the self-testicular examination, and we expect them to do it and tell us whether, they notice any abnormalities. So yeah, that's a great way to monitor and to pick up cases. Thanks.
Probably that's the best or better screening strategy, isn't it?
Yeah.
Okay, I think that's the last question. Thank you so much for your participation, and thank you so much for your great talk, Mar.
Thank you, Linda.
I think, let me just check. There was a question on sarcoma, and I think that's beyond our scope today. Maybe you can ask Prof. Mar directly, but sarcoma of uterus probably can ask Prof. Rosita or Prof. Wan. So I think with that, I thank you again for joining this session on breakfast at UMHealth today. And thank you for your interaction and participation. And I think I close the session today. Any last comment, Mar?
No, thank you, Linda, for great moderation to be with me. She's just next to me in the same room. And thank you to the team, the whole breakfast at UMHealth team.
Thank you.
Yes, and Dr. Shams, right, and his team for great coordination and giving us this opportunity to appear on this platform. Thank you so much. And thank you to the audience for listening. Thanks.
Thank you. Have a great day. Bye.